Hello, everyone. Welcome to Virtual Rounds with Motivate MD. So glad that so many of you guys could be with us tonight. So just to give you a little bit of background about how this is going to go, I'm going to present a case to you with Becca. Becca will be moderating the chat. And if you guys didn't take a look in the chat, she sent a link out for the form that you should try to fill out as best you can as we're going through the case. Because there is a package, a Motivate MD package that you will be entered to win. So make sure that you fill that out and submit it at the end. So my name is Emma. Again, thank you guys so much for being here tonight. So we're gonna go through a case and I'm really excited to share this particular one with you because I am a fourth-year medical student currently in the process of applying to emergency medicine residency. So very exciting. I actually find out next week. So fingers crossed. So before we get started, does anybody have any questions at all? And feel free to unmute yourselves at any point during the presentation and just go for it if you have any questions. I see, share the link. So I will send the link again in the chat. Any other questions before we get started? Can you guys all hear me?
Yeah, we can hear you.
Awesome. Great. Okay, so just a brief overview of the link that you guys were sent. That is a SOAP note. So a SOAP note, if you guys don't know, is the form of documentation that you will someday use with your patients. It's basically how physicians record their encounter with patients. So S stands for the subjective, and the subjective is everything that the patient tells you. So that includes the HPI, which is the story about why they're here, the ROS, which is all the symptoms that could be associated with whatever their main complaint is, like a headache. The patient could also have nausea, vomiting. They could have changes in their vision, stuff like that. So the next part is the objective, and the objective is what you find. So that would be during the physical exam. So as we go through this case, with each slide, you'll be able to figure out what information goes in which part. And if you have any questions, again, please feel free to just shout it out or put it in the chat. And then just to quickly summarize assessment and plan. So the assessment has to do with our differential diagnosis. So typically that's listed in order of what you think it is, what you think the diagnosis is in terms of being most likely to least likely. And today we will have 3 on our assessment. And then the plan is what it sounds like. It's what do you want to do for the patient? Do you want them to follow up in 3 weeks with their primary care provider? Do you want to send them for imaging? Do you want to get labs? So that kind of thing. But if there are no more questions, I think we should get started. All right, I'm going to share my screen with you guys. Perfect. Here we go. And I'm going to have the chat kind of popped up next to me, so feel free to put anything in there as we go along. But just for anybody who just joined, my name is Emma. I'm a fourth-year medical student. I am applying to emergency medicine residency this year, so I find out next week if I match. Fingers crossed, knock on wood. And today we will be going through a case topic in emergency medicine, so I'm a little biased. I think this is pretty cool. I hope you guys do too. And we'll be talking about brain hemorrhages. So let's get started. So this is what we already talked about, outline of how today will go. And then just don't forget to submit your form at the end and you'll be entered to win an awesome Motivate MD package. The form again. Here we go. A 21-year-old male presents to the emergency department by EMS or ambulance with a chief complaint of headache. The patient reports that he was playing in a college rugby game when he was suddenly tackled by several other players. Once the play was over, he was found to be unconscious. However, a few moments later, he regained consciousness and said he felt fine besides having a headache. As you're talking with the patient and performing your initial trauma survey, ABCs, which stands for airway, breathing, circulation, He suddenly loses consciousness again. He is now unresponsive to both verbal and physical stimuli. So in terms of verbal, what I mean is you literally going up to the patient, kind of close to their face actually, and saying, excuse me, John Doe, can you hear me? Can you hear me? Physical stimuli could be as simple as putting your hands on the patient's shoulders and even shaking them a little bit, all the way up to using something called a sternal rub, which is actually a fairly painful maneuver to try to get patients to respond to. So you take your knuckles and you put it on the patient's sternum and you rub. So if you do that to yourself, you'll see that is not comfortable. All right, does anybody have any thoughts before we keep going with the case about what this patient could be experiencing right now? There are no wrong answers, okay? Concussion, that's a really good thought. Definitely can be on the differential, absolutely. Any other thoughts?
Maybe like a brain hemorrhage.
I like what you're thinking. I like it. All right, continue with the case. As an emergency resident physician, you will employ your clinical judgment and determine that the patient needs to undergo an emergent CT scan of his head. We got to see what's going on in there. So here's our differential diagnosis. Number 1, so most likely epidural hematoma. Number 2, subdural hematoma. And 3 is intracerebral hemorrhage. So a hematoma means a collection of blood. And then epidural and subdural are referring to the location in the brain or above the brain where the patient is hemorrhaging. And we will go into more details of anatomy and I'll explain what the different spaces mean. But can anybody tell me what an epidural hematoma is? Feel free to use the pictures as cheats if you want.
Isn't it just like a blood clot in the epidural region? Or like a big clot in the area?
So you are definitely on the right track. It is actually so what happens is a patient gets hit in the head and there is a specific part of the skull called the pterion, which I'll go into, and it's especially thin in comparison with the rest of your skull. And behind that is the middle meningeal artery. So if you guys can see my mouse, it's right here, the middle meningeal artery, and that runs right behind the pterion. And so on occasion, if you get hit, in just the right area, that could cause rupture of that artery. And then you'll get pulsatile collection of blood, which can eventually turn into a clot. So I can't say that you are wrong, but it initially comes from a hemorrhaging artery. That's a really good thought. Any thoughts about subdural hematoma? It's okay. It's okay if you don't know. I didn't know it when I was in your shoes either. So we'll keep going and I will explain all of these. All right, so step 1 is understand anatomy. So first thing we have to talk about are the different layers of basically your head. And within these different spaces, you can get collections of blood, depending on what artery or veins rupture or break that causes bleeding into your brain and the hematoma, the collection of blood. So if you guys can see my mouse, here we have your scalp, so that's your skin overlying your head. You guys know that. We have the skull, which is the bone. And then we have the dura mater. So I'm going to lump these two together, the dura mater. So we have 3 different layers of mater. So what the mater is, it is essentially 3 layers of tissue that cover the CNS or the central nervous system, meaning your brain and your spinal cord. So the dura mater is closest to your skull. And then you have the arachnoid mater, which is just below that right here. And it's named that it's named arachnoid, like spider, because of the way it looks. If you guys can see, it has these projections going down to the pia mater. And the pia mater is unique because it actually covers the brain itself, or the spinal cord itself. So there's a little bit of anatomy. All right, let's get into the physical exam. So how the physical exam is going to go, I want to talk through all of the different findings with you guys, but I'd love it if you could tell me if you think anything is out of the ordinary. So let's start with vital signs. Let's start with heart rate. Does anybody notice anything unusual about patient's heart rate, or do we think that's normal?
I think it's a little low.
I would agree. It's a little bit low. Absolutely. Does anybody know what normal would be? Like the threshold before we get to too low of a heart rate, or bradycardia?
Isn't it about like 65 to 70 in that region?
Really close, really close. So typically 60 is the threshold. If we get below 60, we start thinking the patient is bradycardic. So you were right there. All right, let's go to blood pressure now. 155/80. How do we think that looks?
The systolic is a little bit high, but diastolic's pretty normal.
Yeah, I would totally agree with you. Yep, 155 systolic is a little bit elevated, especially for a patient who is young in college, most likely doesn't have any comorbidities or other underlying health issues. So it's definitely something we want to take note of. What about the respiratory rate? I just have irregular. Does anyone have any thoughts about why it might be irregular? This is kind of a hard question. So think about our differential diagnosis. We have epidural hematoma, subdural hematoma, and then we have intracerebral hemorrhage. What do you guys think might happen if we have blood, pulsatile blood flow from an epidural hematoma, creating a larger and larger area of blood in the brain? Squishes your brain. Honestly, it's as simple as that. It actually compresses your brain, and it can lead to a whole list of problems, like compressing your brainstem where your respiratory center is. So that is why for our patient, he has irregular breathing, is because he's got some serious swelling in his brain. All right, temperature, 98.9. Are we worried about that? Do we really care about that in the emergent setting? No, we don't care. Totally normal. And then SpO2, 95%. So the SpO2 is measuring the saturation, the oxygen saturation in the patient's blood. Do you have any thoughts about 95 is normal, abnormal?
I want to say that's normal, but shouldn't it be like, isn't there a range for it?
Yeah. So for you guys and me sitting right here, it'll probably be between 99 and 100%, 98 maybe. So 95 is a little bit low, especially for such a young patient. And it's another clue into something isn't right with this patient's breathing. So all of these different findings from the HPI, so getting our story from the patient before he lost consciousness, and then doing our physical exam, these are all little pieces that we will put together as physicians to figure out what is going on with the patient and what do we do to treat the patient. Good job, guys. All right, let's talk about general. So general, all it means is, what do you see? How does the patient appear? Do they look like their stated age? Do they appear in distress? Are they comfortable? So for our patient, he's unconscious and he is not responsive to voice, or minimally responsive to voice and external stimuli. So we kind of talked about why that is already, but on our differential diagnosis, what we suspect is because he had this trauma from being tackled during rugby, which if you guys aren't familiar with rugby, it's a fairly violent sport, super cool, but kind of violent, where you don't wear helmets and there's a lot of contact between players. So that's what we're suspecting right now, is he has some trauma to his head. All right, moving on to HEENT. So this is basically, we're looking at the neck and up. So right lateral skull appears swollen due to scalp hematoma. Can anybody tell me what scalp hematoma means?
Is that like dried blood on the scalp?
That's a really good guess. So basically it's like if you guys have ever like fallen and hit your head and you get kind of a goose egg, it's kind of, that's essentially what I'm talking about, is you have trauma to the skin of your scalp, which causes swelling. So that's another clue that we have. There could be some underlying issue here. There could be a skull fracture. We don't know until we do imaging of the head. And then, all right, we have bilateral. That's what this stands for, BL. TMs. Does anyone know what TM stands for? I'll give you a clue. It's in your ear.
Tympanic membrane?
Nice. Very good. Yes. Tympanic membrane. Very good. So we say bilateral TMs, tympanic membranes, are visible without evidence of hematoma. So otherwise, when you guys look in the patient's ears as they're on the gurney, you're doing your quick physical exam before they go straight to imaging, you don't see any blood behind that thin gray membrane in the patient's ear. Does anybody have any thoughts about why it's important to check the patient's ears, especially in a head trauma case?
Do they check for bleeding? Is that why?
Yeah, really good thought. So it's evidence to us that there could be some serious issues with the patient's skull. So fracture of the skull leading to blood leakage behind the ear, behind the tympanic membrane. Yes, exactly. And then nares, I say nares, some people say nares, are clear bilaterally. So all that is you're taking a scope and you're looking inside the patient's nose. Do you see any kind of obstruction? Do you see any kind of like bone from a fracture or a straight avulsion or complete break of the bone? But not for this patient, so that's good. And then we have anoscoria with ipsilateral mydriasis. That is a lot of medical jargon. Does anybody have a thought about what anoscoria means, or honestly any part of this last sentence? Mydriasis. Yes, so Swetha, I was reading the chat, sorry, says checking pupil dilation. So you are dead on. So what anoscoria is referring to has to do with the pupils. And it has to do with the size or the diameter of the pupils. Does anyone have any other guesses as to what anoscoria specifically means regarding the pupils?
Do the pupils like dilate or not dilate?
Oh, you're so close. It is actually that they are different sizes, so dilating at different sizes. Okay. So what this means is ipsilateral is referring to the same side as where the trauma happened for our patient. So for our patient, that's on the right lateral side of their skull. So the right side of their head, where that big hematoma is, that big swelling. And then mydriasis has to do with the pupil appearing large, so having a large diameter versus a small diameter. Does anybody have any questions about what that means or anything we've talked about so far? Okay, well, if you do, please feel free to shout it out. All right, next we're going to move on to CV or cardiovascular. So we have bradycardic. So We recognize that in the vitals, but then we have to rewrite it down here in our systematic physical exam in each system, in each organ system, basically. So bradycardic, and then we have distal pulses are palpable. So does anybody know what distal pulses is referring to specifically?
Like the feet?
Yeah, very good. Exactly. Yep. So there are lots of places that you can check pulses distally. One is the feet, the tops of the feet. That's called your pedal pulse. There's also a place behind your medial malleolus, which is the kind of projection on your ankle towards the middle. You have two of them, the medial and the lateral malleoli. And you can feel a pulse behind that too if you need to check. Yeah, very good. And then we have our palpable pulses in our wrists, or our radial pulses too. And those are pretty easy to feel if you guys check on yourself. Sometimes I do that when I'm nervous. Good. Next we have capillary refill is less than 2 seconds in bilateral upper and lower extremities. Does anybody have any idea what capillary refill is referring to?
Is that like when you push down on your skin and then it turns white and then you refill, blood turns red again?
Yeah, exactly. Nailed it. Yep. So literally you're pinching their finger and then you let go and you count how many seconds it takes for it to pink up again. So you can do that in their fingers, you can do that in their toes. Yes, and less than 2 seconds is normal. So if it's longer than 2 seconds, that is a clue to us that there could be some kind of vascular issue going on, or some reason why blood is moving more slowly than it should. No peripheral edema. That's good. Can anybody tell me, how do we check for peripheral edema in a patient?
Is it swelling and they kind of look like they're water bloated in the areas?
Yeah, nailed it again. Good job. Exactly. So it's swelling, basically. And I don't know if you guys have ever had this experience, but I certainly have. When you are wearing tight socks, and then at the end of the day, when you take your socks off, you see an imprint, especially where the elastic is. So that shows a little bit of edema, but it can actually be quite severe, especially in patients, for example, that have heart failure. They get what's called third spacing, where the fluid leaks out of the vasculature and basically into the soft tissue, into the skin. And what that looks like is the kind of a doughy, squishy feeling. When you test for it, you find the patient's tibia, which is the lower leg bone, one of them, and you push on it. And with a patient that has significant peripheral edema, there could even be an imprint of your finger. So that's just another clue about parts of the body that could be involved in whatever you're assessing. But good news for our patient, he does not have that. All right, moving on to the lungs. C-tab, or clear to auscultation bilaterally, that just means you use your stethoscope and you're listening to all the different locations for checking the patient's lungs. So you can do it anteriorly to check the lung apices, or the top of the lungs, and then there are 4 spots on the back that you want to check too, just to make sure you cover all parts of the lung. Because with traumas, even if you think this is just a head trauma, you always have to check, because there could be other things wrong that you can't see, like a collapsed lung, for example, or a pneumothorax. But his sound clear. We can hear breath sounds on both sides, so that's good. However, we have this irregular respirations, which is really concerning for, does anyone remember why I said that was kind of concerning? Swelling in the brain. Good job, Speakla. Yes, exactly. And to answer your question in the chat, it's less than 2 seconds. That's how long it should take for a patient with no vascular issues to have their blood fill your finger again, fill their finger after you pinch it and let it go. Good. All right.
I have a question.
Yeah, absolutely.
So the irregular respirations, is that causing a change in pressure? Is that why you're getting irregular respirations in the lungs, or is that why it's happening?
Yeah, I like what you're thinking. It actually has to do with the swelling that the patient has going on in their brain. The fact that in the space between the skull, the calvarium or the skull, and the dura mater. There's a space between there. It's like a pseudo space because there's not supposed to be anything in there. And so that's filling with blood. And what's happening is that is putting a lot of pressure on the patient's brain. So much so that it's compressing some of the important parts, like where the respiratory center is in our brainstem. So that's why the patient has irregular respirations. Good question.
Thank you.
Absolutely. All right, MSK or musculoskeletal. No evidence of deformity in the bilateral upper extremities and lower extremities. So in real life, this would probably be much more extensive than what we're talking about today. They would do, you guys as resident physicians would do a very thorough physical exam, and you would denote whether or not the patient has any, lacerations or cuts anywhere, which is likely because he was playing a sport, but I want to keep it simple. So no evidence of deformity or AKA evidence of broken bones, things like that. So that's good news. And then lastly, we have neurological. So unable to assess cranial nerves 2 through 12. Can anybody tell me what's the significance of the cranial nerves? And this is kind of a hard question, but I bet you guys can handle it.
They regulate parts of the nerve system, like heart rate and all this other stuff.
Yes, so cranial nerves 2 through 12 are an excellent way to assess the different structures within the brain, because the cranial nerves enter and exit different parts of your bones and anatomy, and so they can tell us a lot about where there could potentially be damage. For example, you would test the cranial nerves 2 through 12 if a patient has a stroke. And that's important because, like I said, it can give you clues as to where in the brain the patient had a stroke. And a stroke is it can be caused by a couple different things, but one is a blood clot. Does that make sense to everybody? Any questions about the cranial nerves? Some examples of the cranial nerves, which I should have said initially, would be smiling, frowning, closing your eyes super tight, your tongue moving, looking what you have the patient open their mouth and you look at their uvula, which is kind of the drop-like structure hanging in the back of your throat. And for patients, we want to see that's nice and midline, right in the middle of their oropharynx or their mouth, essentially. Other cranial nerve functions could be shrugging your shoulders, turning your head side to side. So that kind of gives you an idea of why that's important. And then also unable to assess sensory and motor function due to loss of consciousness, which is too bad because, again, those can be clues as to where in the brain there could be localized trauma. Does anybody know what GCS stands for? Nice, Sweetha nailed it. Glasgow Coma Scale, exactly. What do we use the Glasgow Coma Scale for? Any guesses? Yes, so Sweetha nailed it again. She said, check their neurologic responses, especially regarding a brain or head injury. So that's exactly what GCS is used for. It's used for patients specifically who have endured a head trauma. And it's a way to assess their, basically how with it they are. So we look at different features like their eyes. Are they able to open their eyes to command? Can they move their eyes? We look at their ability to respond to different stimuli in terms of verbal. Can they have a conversation that's coherent, like I'm doing, trying to do with you guys right now, like normal sentences? Are their words jarbled? Are they just moaning? Are they only able to withdraw to pain? So does that make sense? Does anybody have any questions about the Glasgow Coma Scale and why we use it? Okay, I'm gonna take that as a no. So Glasgow Coma Scale for him is 9. For you and I sitting right here, 15. 15 is the highest it can go, and 3 is the lowest that it can go. So typically, a GCS or Glasgow Coma Scale of 8 or less is an indication that the patient can't protect their airway, meaning they're not able to talk, and we're worried that they could suffocate. So that would be an indication for intubation. Does anybody know what intubation means?
Then a tube put into your lungs pretty much to give you oxygen.
Yeah, exactly. Yep. So it's a tube that goes down your trachea, not quite into the lungs, but just above. So it's sitting in your trachea, and it basically attaches to a ventilator. I'm sure you guys are especially familiar with ventilators right now because of COVID, but it breathes for the patient if they're unable to breathe themselves, or if the physician is worried that they're not able to, they won't be able to breathe down the road. And then I see a question in the chat talking about the Glasgow Coma Scale. How much is it typically scored out of? So the maximum is 15, and then the lowest is 3. So a GCS score of 3 would essentially indicate that the patient was brain dead. And then 15 is just like you and I, we are able to respond to stimuli normally, have a conversation that's coherent, be able to move our extremities normally, or our arms and legs. Good. All right, so there we go. So now we have the physical exam, and I've just put the irregular findings in bold. So we've already kind of talked about a lot of these different things. Do you guys have any questions about any of the physical exam findings or any of the medical jargon? Okay, let's keep going. All right, so we're down to our assessment and plan. So assessment is our differential diagnosis, and we talked about that a lot already, about what that means. So differential diagnosis includes typically what we think is going on in terms of most likely to least likely. So most likely because of this patient's trauma and because of how he presented, specifically that he was in this traumatic situation playing rugby. People piled on top of him because he had the ball. And then when they got off him, he was unconscious, but he woke up again. He woke up again. He said he was okay, just kind of had a headache. And then after we talked to him for a while, when he arrived in the emergency department, he lost consciousness again. And that's really important. That's another piece to our puzzle. That's called a lucid interval. And that is a clue that we could be dealing with an epidural hematoma. See a question. In real life situation, about how long would it take a physician to find out all of this information? That's a great question. So as a resident physician, I'm not a resident yet, but just from my experience in emergency department with residents, they move pretty quickly. You know, you guys will get very comfortable with wielding your medical acumen or all of this medical knowledge that you've spent years building and refining, and you will continue to do that throughout your practice. But in real life, you have a whole team of people there. So it's not just the physician, it's the resident physician, it's the attending physician or physicians, it's the nursing staff, and you have all these people working together to do things as fast as possible, because with pathologies like an epidural hematoma, that is a life-threatening condition that you need to diagnose quickly so that the patient can be treated appropriately. So that's a really good question. See another one. Is the Glasgow Coma Scale any different for younger children or infants? That's a really good question. I do not believe so. Good questions. All right, so back to our assessment and plan. Number 1 on the differential, epidural hematoma. So what do we need to do for this patient? We've done our physical exam, we've assessed the patient, we think it's an epidural, so we need to get a head CT. That's going to be number 1 thing to do to confirm our suspicion. So does anybody know why it's important that we do not use contrast when evaluating for a brain hemorrhage?
Is it because of the bleeding?
Yeah, exactly. Can you tell me more about that? What does that have to do?
Well, I'm assuming that they're because they're both liquid, so I assume that on the scan it'll look like the contrast is blood.
Nailed it. I'm so impressed right now. Exactly. Yes. So in an acute brain bleed or a fresh brain bleed, the blood shows up as bright white. And if you give a patient contrast, that also is bright white. So it would hide anything, it would hide all the stuff that we're trying to look for. So that's why I have without bolded in CT without contrast. So very good. Next on the list, we have consult neurosurgery stat. So like I said earlier, this is a life-threatening emergency, a life-threatening neurosurgical emergency. And the way that this is treated after we diagnose this with a CT is the patient goes to the OR. And if you guys see the pictures down below, here we have a scan, a CT of a patient's head with an epidural hematoma. And then this would be what a craniotomy could look like. Craniotomy meaning that they remove a portion of the patient's skull and evacuate or suck out the blood, the congealed blood right here. And then lastly, I have continuously observe vitals and watch for patient decompensation until the patient can be taken to the OR for urgent craniotomy and hematoma evacuation. Does anyone know why it's important to keep an eye on the patient, especially their vital signs, while we're waiting for the neurosurge team to bring them to the OR? Yes, good job, Smita. She said, make sure their state doesn't change drastically. Exactly. So we want to monitor their vital signs in case the brain swelling affects their respiratory drive so much that they can no longer breathe. That would be an indication that this patient needs to be intubated right away. So there's no point in taking them to surgery if they pass away before they can even get to the OR. So that's why we want to be very careful with this patient. Always have somebody in the room with them, be monitoring them, and make sure that they don't decompensate or go downhill, stop breathing, or develop any other problems before they can get to surgery. Good job. All right, let's talk about some path. So this, you guys will learn so much about your first year, but mostly in your second year. You'll learn about all the different pathologies of the body, all the different organ systems. So for us today, we're talking about the brain and specifically hemorrhages. So what is an epidural hematoma? So I know I already talked to you guys about what this is, but can somebody just summarize what makes an epidural hematoma an epidural hematoma? Feel free to use a picture. Okay, I'll say it again. So what makes an epidural hematoma unique is that typically what happens is the patient has trauma. Yes, Ronald nailed it. Blood pooling right above the dura mater. Exactly. So just to take a step back for a second, we talked about a specific artery that can rupture or break due to trauma in a specific part of our head. So I have a picture, which I will show you guys in a moment, but that area of the head, the lateral side of your head, is called the terion, and it's where different bones that make up your skull come together. And that is a very thin part in comparison to the rest of your head and is vulnerable to trauma. And I don't know why this happened, but there is an artery right beneath it called the middle meningeal artery. And if you get hit in just the right spot hard enough, that can cause damage to the middle meningeal artery, can cause rupture. And that's what causes the bleed. So it's an arterial bleed. As you guys can see, the red blood, arterial blood, that comes from the ruptured MMA, or the middle meningeal artery, between the skull, or the calvarium, which is the bone, and your brain, essentially, which is covered by the different layers of the meninges, or the dura mater, the arachnoid, and then the pia mater. Good. All right. So I say under what is it, that it's most commonly due to trauma, just like our patient unfortunately getting tackled. Good. So we already kind of talked about that. Does anybody have any questions at all about what I've mentioned? All right, let's keep going. Awesome. So here is just a refresher for anatomy. This is the uterine right here. That super fragile part of your skull on the side of your head. And as you guys can see, there are different parts of your head, different parts of the bone that make up your calvarium or your skull that have different names. So this is the frontal bone, for example. The pink is the sphenoid. We have the temporal and then the parietal. And the little jagged edges between all of these are called sutures. And where the sutures all come together here, unfortunately, is right where that middle meningeal artery is located. So that can spell trouble for young people who are playing sports and just get hit in the wrong place. And then some review of radiologic findings. So what do we see when this patient comes back from his head CT? We see this. So here, right here, we can see that hematoma that I was talking about that you guys actually found on physical exam. So we have that swelling from broken blood vessels, from trauma, from getting kicked or punched or whatever happened to him in that big hog pile. And then here, this is where the money is. This is where the big problem is. All that bright white is blood, and that spells trouble for our patient. And as you guys can see, this here is causing some compression on the patient's brain. It's in this picture, it's not quite causing a shift, but sometimes what you can happen is between the lobes of your brain, if you can see my mouse here kind of outlining the different lobes of your brain, is if you have enough pressure from a bleed, this can cause what's called a midline shift, which is really bad. That means that there is enough pressure in your head from a bleed, for example, that it's causing your brain to shift over and be squished on the other side of your skull. So what's unique about an epidural hematoma in terms of its shape is that it's referred to as lenticular, like a lens. And that's important because what this shows us is that it doesn't cross suture lines. Suture lines meaning the different parts of your skull. And if you guys remember the jagged edges where the different bones of your head come together, that's what I'm talking about with sutures. So this does not cross any suture lines. It stays in one particular place. And we will compare this to another kind of brain hemorrhage called subdural and how that looks different. So that's an important finding. All right, subdural, here we go. So as you guys can see, I'm just gonna jump right to the picture. This is a completely different shape, completely different shape. Does anyone have any guesses as to why it's different?
Is it because of the layer that it's in?
Yeah, yes, exactly. So this is different because it does cross the suture lines of the skull where all those bones are coming together because of its location. Very good. And this, does anyone know what the shape is referred to? I did not expect you to know, but just thought I'd throw it out there. So the epidural hematoma we refer to as lens-shaped or lenticular. Any thoughts about what this looks like? Crescent shaped, yes, we nailed it, I love it. Crescentric or crescent shaped, exactly. So as you guys can see, this is why it's so important to know, be able to recognize on imaging, for example, what these different brain hemorrhages look like, because they're so different and they mean very different things. So let's talk about what is a subdural hematoma. So can any of you guys give me an idea of what it is? Blood hemorrhaging below the dura but above the arachnoid. All right, so we talked about the different layers of basically between the skull or the calvarium, the bone, and then the brain. And what we have the 3 layers of the meninges. And between the meninges, you can have what's called a pseudo space. So you could have a space there, but you're not supposed to. And you can get a pseudo space when, for example, you have an epidural hematoma, or even a subdural in this case. So exactly. We have bleeding that's causing this crescent shape. Does anybody know what causes, I know it's on the screen, but does anybody know what causes the bleeding? So the last one, epidural, was an arterial bleed, which makes it unique, makes it different. What about for subdural? So it's the bridging veins. So this is a venous bleed, which makes it different again. So the shape, the type of vasculature that's affected, artery versus venous, those things are all very important when you're trying to figure out what is causing these abnormal symptoms in your patients. So caused by tearing of the bridging veins, and the patients who are most at risk for this kind of bleed are actually on the extremes of the age spectrum. So very young, like neonate or a baby that's just born, and then the very old. And the reason why that is because when you age, when you're very young and when you're very old, you tend to have more strain on the bridging veins. And what that can do, let me back up a second. So for example, in an older patient, typically patients as they age, they get atrophy of their brain. It's just kind of a natural part of the aging process, is your brain shrinks a little bit. And that puts stress on those veins. And so if you fall and you hit your head as an older patient, you can have a brain bleed from a subdural. I see a question. Is there a way to know if the injury is still bleeding or has stopped based on the scan? That's an excellent question, and yes, the answer is yes. So what's unique about a subdural hematoma is that instead of it not necessarily being an acute problem, it could be a chronic bleed too. So because this is a venous bleed compared to an arterial bleed, the bleeding can actually be slower than what you would expect. Sorry about that. So it's slower than an arterial bleed, which is more pulsatile versus a slower leak. And it depends on like how many of the bridging veins are affected and things like that. But yes, you can have a slower bleed. And so on a scan, what that would look like is the blood would be much darker. It wouldn't be that bright white if it was what would be called a chronic subdural hemorrhage or hematoma. Good question. And then one other risk factor I just wanted to mention is alcoholism. Does anybody have a guess as to why alcoholics are more at risk for a subdural hematoma versus another person in the population?
Did they affect platelets or something?
Sorry, you cut out. What did you say?
Do they affect platelets or something to do with clotting?
Yeah, very good. So alcoholics drinking a lot, that can affect your liver, and that can make you prone to coagulopathies or trouble clotting your blood, because a lot of those factors come from the liver. So exactly, that's why. And then another reason is because alcoholics, as you guys may or may not be aware, alcohol changes your sense of equilibrium, or where your body is in space, and it makes it much easier to fall and hurt yourself. So having issues with the coagulopathies or being able to clot normally, have your blood clotting cascade function normally, and then also potential repetitive trauma from falling puts these patients at more risk. Very good. There we go. I see another question here. So would that make people with inner ear balance issues also high risk? That's a really good question. And I would say it depends on how old they are. I think vertigo is typically more common in older people, so that could potentially make them more at risk for falling and having than having a subdural hematoma. Good thoughts. All right, now we'll talk about last item on our differential diagnosis, which is intracerebral hemorrhage. So as you guys can see, this looks totally different than the other two scans that we just looked at. Epidural, we saw that lenticular shape. It was very confined. It didn't move. Subdural was more of the crescent shape that kind of went around the skull. And here we have intracerebral, where it's literally inside the brain. So instead of pushing on the brain from more of the outside, having to do with the different layers of your dura mater, arachnoid, and then pia, here is within the brain. So does anybody have any thoughts about who is most likely to have an intracerebral hemorrhage?
Maybe someone like cardiac issues.
Yeah, yep. Good job. Yes. So I see in the chat someone says high blood pressure. Exactly. That's what hypertension means. Nailed it. And then cardiovascular issues. Yes, which can cause high blood pressure. So as you guys probably are aware, there is a condition called atherosclerosis, which means hardening of your vasculature, which puts patients more at risk for developing heart disease over long periods of time. Including hypertension. And long-term hypertension has a ton of bad effects. It's really important that patients manage hypertension with their primary care provider so that they don't have long-term sequelae or consequences of chronic high blood pressure. But one issue that patients can get, especially if their blood pressure is consistently very high, is an intracerebral hemorrhage. Another kind of patient that is prone to an intracerebral hemorrhage would be a patient who has an AVM. Does anybody know what AVM stands for? I do not expect you guys to know, but you've just impressed me so much.
Is it like an acute ventricle of something? I know someone that used to have that.
No, it's not.
Okay.
So it's an arteriovenous malformation. Again, I do not expect you guys to know that. So what that means is patients have an abnormal formation of their vasculature, essentially, in their brain. It's the veins and arteries come together in a way that's not how they should, and that puts them at a greater risk for developing a hemorrhage. So how specifically does hypertension lead to hemorrhage? So having an increased strain on your vasculature over time, especially if you have very high blood pressure, it hardens your arteries. It actually makes them, in a way, more sensitive to breakage. So that's one reason that atherosclerosis is so dangerous. Your vasculature just isn't as stable as it should be. Does that answer your question? Awesome. Good. Any questions about intracerebral hemorrhage? Okay, let's keep going. Is there a name for the shape? Great question, Sweeta. Not that I'm aware of. So there could be, but I don't believe so. All right, diagnosis. So going back to our patient. So reviewing, how did we figure this out? How did we figure out that the patient had an epidural hematoma? We see on physical exam findings and from our HPI talking with the patient, learning about the trauma, that he had this lucid interval, meaning that he was unconscious from the initial trauma, and then he woke up and he was doing okay, actually, just had a bit of a headache, and then he lost consciousness again. That's called the lucid interval, and lucid interval is very specific for an epidural hematoma. Our abnormal vital signs are the Cushing triad. So Cushing triad has to do with some of the vital signs that we were talking about earlier. So our irregular respirations. So, what I mean by that is, as we're sitting here, you guys are probably breathing at a normal rate. So irregular respiration means that maybe the patient takes a breath and then it's kind of a long time before they breathe again. So that's what I mean by that, as I tried to demonstrate. So other parts of the Cushing triad would be bradycardia, or having that low heart rate. I think our patient had a heart rate of 50. Good. And then signs of elevated intracranial pressure. So patient complained of a headache. Other symptoms of elevated intracranial pressure, because as you guys will learn in medical school, there are many different causes of elevated intracranial pressure. And that can cause symptoms like vomiting. Vomiting is a very kind of non-specific finding, but is also important because it presents in so many different things, like intracranial pressure when it's elevated. Differences in pupil diameter, or anoscoria. That's super important because it tells us that there's something wrong with the brain. And what we think it is there's a bleed in there and it's putting pressure on the cranial nerves and it's causing the pupils to be different sizes. One is big. There's mydriasis on the ipsilateral side, meaning that one pupil is big on the same side, the right side of the head where the trauma was, versus the other pupil, which is small. The scalp hematoma, which could be an indication of a fracture, a skull fracture, which is really dangerous. Let's see, would the anoscoria cause any effect on the patient's vision? That's a really good question. So what I would say to that is it could cause more blurry vision in the patient's ipsilateral eye, or the eye on the right side, because typically, as you guys know, when the light changes in a room, your pupils adjust for that. And if your pupils don't adjust, that can make it more difficult to see. Great question. On imaging, so here we have, again, that lenticular shape, and then evidence of that scalp hematoma from swelling here. There, we can see this is also bright white, so there's some blood in there. It's lenticular because it does not cross the suture lines like in the subdural where it was the crescent shaped. Good. Any questions about that? No? Okay. In this picture, I think it's a little bit easier to see the pressure, just how much pressure this bleed is actually causing on the brain. So the midline should be right here, but it looks like the patient's brain is actually moving a little bit. Thank you for coming, Lance. I really appreciate it. Thank you so much. Hope to see you again.
Thank you. Thank you.
Great. All right, we'll keep going. So evaluation, again, how we figured this out with diagnosis and evaluation, and our plan for the patient. What do we want to do now that we know what's going on? Order a head CT. That's the most important thing that you can do. Next is call neurosurgery, because this is a neurosurgical emergency. You have tremendous pressure being put on the brain because of this blood that's filling the skull, and that can cause long-term damage or put a patient in a coma or even death if you don't correct that as soon as possible. So consult neurosurgery. Great. That's it, guys. That's all I got for you. Any questions at all? About anything. It doesn't have to be about the presentation, about med school or whatever. Thank you so much, Ronald. Thanks for coming. So what would they do in surgery to evacuate the blood? They would do a craniotomy. So what that means is they literally take a drill and they cut a hole in the patient's head to remove the bone, and then they essentially clear out the blood, vacuum it out, suck it out, and if there is still like pulsatile bleeding, they'll try to control that bleeding. But that's what a craniotomy is. It's pretty crazy. Good question. Any other questions at all? Okay. Well, thank you guys again for coming. Loved having you. Love Grand Rounds, super fun. I get to talk about awesome things and meet cool people. So if you have any questions, feel free to either call the number below or send an email to support@motivatemd.com. And make sure to send in your SOAP note. It doesn't have to be perfect. That's not the point. It's just getting familiar with how you document the patient presentation, what they tell you, et cetera, and you'll be entered to win a really cool Motivate MD package.